Hi, and welcome to MedEd's production of the CEN Exam Review. This first educational module that we're going to do together is entitled Mental Health Emergencies. And I can almost hear it through the camera, the groans out there, because I know that for many of us in emergency nursing, not all, but many of us, psychiatry and patients with mental health conditions can create one of the biggest challenges that we offer. But because it is so much a part of what we do in the emergency department, you will find questions on the exam related to mental health emergencies. So let's cover it. Let's start, as I said in the opening lecture, with a challenge question. Now remember, I'm giving you the question now before the material because I want to challenge you, kind of like a pre-test. Do you know the information? So I'm going to read the question to you, and then I'm going to recommend that each time we come to these challenge questions, you take a moment to pause the video and really give it thought, because remember, half of passing this exam is being good at questions. And by taking the time to learn to read them, to interpret them, is really one of the best ways that you can help prepare for the exam. So here's the challenge question, and if you need to, flip to the back of your manual, because I've put them all there if it will help you to read along in your manual and to take notes there if you want to. So, a patient presents to the ED in the manic phase of a bipolar affective disorder. Which of the following statements made by the emergency nurse is most therapeutic for a patient with this diagnosis? A, I want you to tell me what you are feeling right now. B, I need you to stay in this room and someone will stay here with you. C, tell me what is going on in your life right now that may have made you feel out of control for the past few days. D, we are worried that you may be a danger to yourself or others in your present state. So we're going to have someone from psychiatry come down and discuss with you what you are feeling. All right, I'm moving on, but take the time to really think about that question and see if you can get it right. I'll tell you the answer in just a bit. So let's start with thought disorders. Now, thought disorders are, as the name implies, going to cause an alteration in thought. And remember, alteration in thought is known as psychosis. Psychosis is this alteration in the way we think, in the way we perceive the reality in which we are in. I mean, right now, I'm sitting in a studio and I'm teaching a CEN review class, right? And so for those of you that are watching, you're probably sitting in your home or wherever you're at and watching this review class. And if we're all on the same page, probably none of us is psychotic. But if one of you thinks you're sitting on a spaceship right now, then you're probably psychotic because you're not matching the reality of the rest of us who are doing an online CEN review course. So the person whose reality doesn't match the others would be psychotic. Now, if you're all on a spaceship and I'm the only one teaching a CEN review course, then guess what? I'm probably the psychotic one. Speaking of psychosis, watch this dog. Tell me what you think about him, all right? Well, I don't know if that dog's psychotic or not, but you have to feel sorry for him, right? Anyway, when we talk about psychosis or alteration in reality, we recognize that there's several things that can cause a patient to have psychosis, and they're listed there on your screen. Schizophrenia, delirium, depression, mania. Let's look at these independently. Let's start with schizophrenia. Schizophrenia is known as a disorder of thinking. It's a chronic disease. Once you have it, it's yours for life. Now, most people will begin to show symptoms of schizophrenia in their adolescence. At most, they may begin exhibiting symptoms in their 20s, but it really never starts after the age of 30. So there you go. For those of you that are 30 or over, you can cross that one off your list as something to worry about because you're probably not going to become schizophrenic later in life. It usually shows up, as I said, in adolescence. But sadly, once you begin to display the behaviors of schizophrenia, you never return to baseline. It's marked by bizarre thoughts, bizarre behavior, often suspicious behavior. The patient also has social awkwardness as a symptom. Now, the symptoms of schizophrenia can be divided down into positive and negative symptoms. And here's my honesty moment for you. I didn't understand this positive-negative thing for years, so I simply didn't teach it because, well, you shouldn't teach something you don't understand. But I finally got it in my brain. So let me see if I can teach you in a minute what took me years to learn. All right, here we go. Now, a positive symptom is a symptom that the person with schizophrenia will exhibit, but those of us without schizophrenia will not exhibit. Okay? Now, if you look at the examples on the screen, they're kind of obvious, right? Hallucinations, delusions, thought disorganization. I don't have schizophrenia. I don't experience them, but the patient with schizophrenia does. So they're positive because the patient has it and I don't. So, perseveration is another positive symptom. Perseveration means to return to or focus on the same thought and kind of get stuck on that. Again, that's positive because the schizophrenic experiences it, but I don't. Ideas of reference and ambivalence are also experienced by the schizophrenic, but not by me. So those are positive symptoms. Now, a negative symptom is a behavior that I exhibit, and I'm not schizophrenic, so if I have the behavior and they lack it, then it's a negative symptom. Look at the examples on the screen. Apathy. I care, they don't. Alogia. I speak, they don't. Flat affect. I have emotion, they don't. Anhedonia. I feel pleasure, they don't. Avolition. I finish a task, they don't. So the things that I do but they do not do are negative symptoms, and the things that they do but I do not do are positive symptoms. How confusing is that? But I hope it's actually a little more clear after that explanation. Now let's move on to another common cause of psychosis, which is delirium. Delirium is an alteration in reality due to a physiological disease or imbalance in the body. Now, on your screen and in your book, I have listed the common causes of delirium. Now, if you look at the list, you're going to notice that there's a mnemonic that might help you remember these major classifications of things that cause delirium, and they are I, watch, death. If you look at the first letter of the words in the left-hand column, the first letter spells I watch death. And that might help you remember all the different causes of delirium. But you're going to notice that delirium means the patient has some sort of a disease process or an imbalance in the body that causes them to lose touch with reality. Oh, there are so many things listed there, from electrolyte disorders to acid-base disorders to sepsis to brain tumors, and all kinds of things in between all of those. I won't read the entire list to you. But you've probably cared for somebody who, for example, is going through alcohol withdrawal. Now, alcohol withdrawal is obviously not schizophrenia. It's a physiological problem that causes the patient to be psychotic, to see things in the air, to hear voices, to lose touch with reality. So that's an example of delirium. The sad news is that delirium carries a mortality rate as high as 20% because the patient may die from whatever's causing the delirium before we recognize and fix it. Now, on the right-hand side of your screen, I have kind of compared delirium to a psychiatric disorder such as mania or schizophrenia. So let me just quickly go through the table with you. The onset. Most of the time, if the patient has a psychiatric disorder, the onset of psychosis will be sudden. They'll very quickly switch from reality to lack of reality. Whereas with delirium, the patient may slide into it on a slower rate, and that's of course because the disease process, such as the electrolyte imbalance, has to develop, so it has a more gradual onset. Now, over a 24-hour period, patients with psychiatric disorders tend to be stable and they remain in their state of psychosis. Whereas a patient with delirium may fluctuate and may have periods where they're more lucid and periods where they're more confused. So we see it fluctuating more with delirium. Now, from a level of consciousness, rarely does a psychiatric disorder cause an alteration in consciousness, whereas many of the causes of delirium will also affect the level of consciousness, and the patient can either have a reduced LOC or a hyper-alert state. Attention and cognition tends to be very disordered with delirium. The patient's confused, they can't think clearly, they can't make good decisions. Whereas a patient with a psychiatric disorder may be able to continue to make decisions even though they have an alteration in their thought processes. Hallucinations. Now, most patients with a psychiatric disorder are going to be limited to auditory hallucinations. They usually don't have like tactile or olfactory hallucinations. Most, again, your psychiatry patients are auditory. Now, your patients with delirium will also have auditory hallucinations. They're more likely to also have visual hallucinations. So seeing bugs or whatever. Think of delirium tremens as an example. Delusions. Most of the time with psychiatric conditions, delusions are sustained. If the patient believes that, they are running the world from a chip in their brain, that's going to be kind of that constant psychosis they have. And it doesn't change much. They stick to it. Whereas a patient with delirium may be all over the place, and their hallucinations and delusions may be very different and unconnected, and so you don't see that organization that we see with psychiatric conditions. And finally, movements. It's not uncommon for many of the disorders like electrolyte disorders or delirium tremens to cause a patient to have abnormal muscular movements. So we may see tremors or asterixis. Remember, asterixis is where the patient can't hold their hand up. When they try to hold that position, their hand flaps. It's called asterixis. And those conditions tend to be associated with neurological disorders, and many of your causes of delirium are neurological. So you may see those abnormal muscular movements. Rarely do we see those with psychiatric conditions. So that just kind of puts these two next to each other. So how do we work with the patient who is psychotic? Well, let's talk about communicating with them. Patients who are psychotic often know that their reality is fractured. And it can be frightening. I mean, I've never experienced it, but I can't imagine not knowing the voices that you hear, whether they're really there or whether they're part of your imagination or part of your disease is a better way to say that. And so it can be very frightening for them. And sometimes people with psychosis, especially schizophrenia, will find that putting limits on their behavior is comforting because they don't know where reality begins and ends, and they need somebody to help them control that behavior. I sometimes will watch YouTube for interest's sake, and one night it came up on my YouTube feed about a young man, he was probably in his late teens if I had to guess, with schizophrenia, who was beginning to hallucinate. And he chose to videotape the process of him going through the hallucinations to try to give us an idea of what he was going through. It's a fascinating video to watch him. And, you watch as he slowly begins to hallucinate and the fear he experiences. And he tells the people in the audience sometimes that he doesn't know if that voice is real. Is it coming from the computer or is it in his mind? And he talks about how scary that is. I can't imagine living with that. But the reason I say all that is one way to help provide comfort to the patient with psychosis is to set limits on their behavior, because that may comfort them if they know what they are and aren't allowed to do, because that puts boundaries on their reality. Now, they don't respond well to threatening. Telling them that you're going to restrain them or do other things that they don't want will not necessarily get a good response. So I'm not talking about threatening them, but being confident when you approach them and setting boundaries on their behavior. keep your sentences brief. They say that a patient with psychosis probably can't process more than 8 to 10 words at a time. So you want to look for very brief sentences, both in reality and even on the exam. If they ask you a question like, what would you say to the patient? You'll want to look for a fairly brief statement because it's more likely to be correct. Always talk about things grounded in reality. If something's not in the moment, in that reality, then the person is more likely to have delusions. So if I'm working with a patient with psychosis and I'm trying to ask them what kind of job they have, well, their job is not in the room in the emergency department. So that's more likely to cause them to delude. And then they may begin to tell me about some obscure job they have as, an advisor to the military or whatever. I mean, I'm just making all this up, of course, but you want to talk about things that are in the reality, in the moment, that they can see and hear and experience. And if you do that, they're less likely to have delusions. Now, if the patient does begin to delude, you have a challenge. Because if they have a delusion, we're not supposed to deny the delusion. Because you aren't going to win that argument, right? If somebody believes they're the President of the United States, you aren't going to talk them out of it. And to try to do so would be a waste of your time and a frustration for them. So we don't talk them out of their delusions, but we should also not involve ourselves in the delusion or reinforce it. So if my patient says he's the president, I'm not going to become his chief of staff during the visit as, a way to make things easier. That wouldn't be appropriate. So let me ask you, if I don't deny a delusion, but I don't involve myself in it, how do you manage a delusion? If somebody starts telling you, for example, that they're the President of the United States, how do you approach that patient? Well, the best answer, and the answer for the exam, is to do exactly what I said. Don't deny the delusion, but acknowledge that it's the patient's. So you might say things like the voices that you're hearing, the things that you're seeing. When I say it that way, I'm not saying they don't have it, but I am saying that I am not experiencing it by calling it your voices, the things you're seeing. So you might want to approach it in that way. One of the questions I wrote says, a patient's in a room and he screams that the walls are closing in on him. How do you respond? And the correct answer is something along the lines of, it must be frightening to see the walls closing in. However, I don't see that. So I'm not denying he's not experiencing that. I'm telling him I acknowledge your experience, but I'm also saying that's not part of my reality. And that helps the patient differentiate his reality from the reality. Also, avoid figures of speech like hungry as a horse or pulled my leg, because those could be misconstrued, right? We'll also want to explain actions in advance, like taking a temperature or a blood pressure, because the patient may misconstrue those if we don't do good explanations, and then the patient may become violent. And finally, we want to try to maintain fairly similar eye levels with these patients. Otherwise, we have power discrepancies, and power discrepancies can result in violence. So if you walk into a patient's room who is potentially psychotic or psychotic, and they're sitting on the stretcher, ideally you would sit as well. Because when you're both sitting, you're at the same level, and you don't have a power discrepancy which threatens the patient, leading to violence. But the opposite would be true. If I'm sitting at the nursing station and the patient walks up to the desk and they're standing, ideally I would stand, because then we have the same eye level and that patient doesn't have dominance over me. So think about assuming those levels. Now, the way that we manage most psychoses, especially those due to schizophrenia and then to a lesser degree sometimes delirium, is antipsychotic medication, which can be very effective. However, we do need to mention that your antipsychotic medication can cause extrapyramidal symptoms. Now, the newer generation causes less symptoms, but they can still occur, so we need to recognize the symptoms and know how to manage them. So what are some of the extrapyramidal symptoms your patient may experience? Well, they may have dystonia. Now, dystonia translates to be disorganized muscle movements. And these patients can have any variety of muscle movements. Maybe they get torticollis where their neck is twisted backwards, or they can get a blepharospasm where their eyelids clamp shut and they can't open them. And they have no control on the muscle. It can be scary, especially if it's their first time. It can also be somewhat uncomfortable. So we need to recognize and manage that to relieve the patient's anxiety and discomfort. Another extrapyramidal symptom related to antipsychotic medication is akathisia, that inability to sit still, that need to constantly move. It might be pacing back and forth nonstop in the room, or crossing the legs from one side to the other, or constantly fidgeting, but they can't stop. Now, sometimes we can misinterpret this as agitation or anxiety or mania. We got to be careful and recognize that that may actually be a side effect of the medication that the patient is taking. Now, there is a life-threatening extrapyramidal symptom known as neuroleptic malignant syndrome, or NMS. Now, NMS kills patients potentially. It often starts with a change in mental condition. So you have this patient who may have been on meds for a while and they were stable and they had less symptoms, and suddenly they become confused or agitated or even have a decreased level of consciousness. This may be the first sign of NMS. At the same time, it's not uncommon to see their temperature start to climb dramatically, and the patient can get really high temperatures. I'm talking about 107 or above at times. The patient at this point may also begin to develop severe muscular rigidity. Sometimes it's called lead pipe rigidity, because like their arms and legs may stiffen like a lead pipe. And then, in the worst case scenario, the sympathetic nervous system can fail. They can develop complete autonomic instability and lose the ability to control their pulse and their blood pressure. There's a lot of reasons why this one's life-threatening. It can be life-threatening because of the inability to breathe due to the muscular rigidity. It could be the high temperatures. Could be any variety of things. The inability to control the blood pressure and pulse. But whatever, these patients can end up with a severe condition, which often requires critical care and sometimes will result in death. So, when do these extrapyramidal symptoms tend to show up? They tend to show up either shortly after starting on an antipsychotic medication or changing the dose of the medication. Now, for dystonia and akathisia, the best thing we can do is to put these patients in a low stimulation environment. That may help reduce some of the rigidity. And then diphenhydramine or benztropine can be used to reduce the rigidity of dystonia or the movement of akathisia. Now, for neuroleptic malignant syndrome, this is a life-threatening condition. Needless to say, we need to stop all offending medications, begin aggressive cooling measures. Because these patients have such severe muscular rigidity, they may need airway protection up to and including intubation. You're going to need to use medications to stabilize their blood pressure and pulse. And then to reduce muscular rigidity, medications such as dantrolene or amantadine or other meds can be used. Do you recognize those meds? Where else do we use, like say dantrolene or dantrium? For malignant hyperthermia, right? Now, malignant hyperthermia is caused by anesthetics, but it causes a very, very similar reaction to NMS. So they're kind of cousins of one another, caused by different things, but both treated with dantrolene. So, we said psychosis can be caused by schizophrenia, delirium, but it can also be caused by depression and mania. So let's talk about those two. Let's talk first of all about depression. Now, if you look on your screen or in your handout, I have listed the symptoms of depression. And to be diagnosed with depression, you have to have at least 5 of those symptoms lasting for 2 or more weeks. That's what it takes for a diagnosis. Now, I won't waste your time reading the list to you. You can read the list as well as I can, but make sure they're pretty obvious, but make sure you're familiar with them for the exam. Now, we also know that you can have some symptoms of depression that may be age-related. So aside from all the symptoms I just showed you, children may also become increasingly hyperactive. They may show regressive behavior and go back in their developmental stages, and may have things like enuresis. Those could be signs of depression in the child. Now in adolescence, signs of depression may be delinquency, sexual promiscuity, and the patient may develop a more cynical, detached, angry, hostile attitude, or may become more socially isolated. Those are adolescent signs of depression. And then in the adult and elderly, they may lose the desire for personal hygiene. They may let their appearance go. Loss of interest in a social life, decrease in sexual activity, or inability to concentrate. So just know that there are some age-specific signs of depression as well. Okay, here we go. So speaking of the elderly, watch this video. Sometimes you get your just desserts in life, don't you? Right? All right. So, of course, the way we manage depression, aside from counseling and other things, but on a more emergent level, is going to be the use of medications. While there's a lot of families of medications that can be used for depression, today we really rely on two families. And those are the selective serotonin reuptake inhibitors, or SSRIs, and selective norepinephrine reuptake inhibitors, the SNRIs. Now, I've given you examples of these two meds in your book and on the screen, so I won't read them. And I've also given you the side effects that you should be familiar with, because part of teaching in the emergency department is knowing what side effects to expect, and if the patient has these side effects, being able to relate them back to the meds that were given. So again, I won't read the list to you, but I would recommend that you be familiar with the list for the exam. Now note that the symptoms of these two meds, the side effects of these two meds, are fairly similar, except your SNRIs have less sexual dysfunction. So they're often preferred by patients, especially if they're in a time when there's a lot of, they have high sexual needs. But your SNRIs may cause more of an elevated BP and may cause urinary retention, which your SSRIs do not cause. Now, I don't know that this is a huge secret, but I think it's worth mentioning that part of the teaching and part of the things we have to be familiar with is that shortly after starting on these meds, especially with your SSRIs, there's a higher risk of suicide, especially in younger patients. So we need to be aware of that when patients start on these meds. And it's also important to teach patients that the effects of antidepressant medications usually take several weeks, so they're not going to have an immediate relief of symptoms. And finally, patients need to be cautious when taking these meds, not to stop them abruptly, because there is a withdrawal syndrome that you can have by suddenly stopping these meds. Now, the good news is the withdrawal from these meds is usually not life-threatening, it's just uncomfortable. And it gives the patient symptoms like nausea, vomiting, fatigue, myalgia, vertigo, headache, insomnia, paresthesias. So there's nothing life-threatening there, but it can be very uncomfortable. So patients need to work with their practitioner to decrease the dosage over time to prevent withdrawal if they're going to stop these medications. They shouldn't cold turkey, and we should just do that as part of our teaching with them. So we've talked about depression. Now let's talk about the manic side of bipolar affective disorder. So many people with bipolar will, as you know, fluctuate between mania and depression. Now that fluctuation is very individual, and some people can fluctuate between the two moods within minutes, but others it may take hours, days, or even months or years in between the mood swings. Now, the symptoms of mania again, are well defined, and you have to have these symptoms for at least 1 week. So let me quickly read the list that's on the screen. These are your symptoms of mania: inflated self-esteem or grandiosity, decreased need for sleep, pressured speech, flight of ideas or racing thoughts, easily distracted, increase in goal-directed activity or psychomotor agitation, and involvement in high-risk activities, especially high-risk sexual activities or financial activities, spending a lot of money in a short period of time, right? So you have to have those symptoms for at least a week to officially be deemed manic. Now, how do we manage the patient who comes in with mania? Well, these patients are a little different than the other thought disorders in that they don't respond as well to authority as we see, for example, this patient with schizophrenia responding. Because these patients will rebel to authority. So we have to be a little less authoritative. With the schizophrenic patient, they might have found comfort in setting boundaries, but your manic patient may rebel against a boundary, so we have to be careful. We also want to be non-threatening, just like all other patients with psychosis. So look for answers on the exam that are non-authoritative and non-threatening. Another thing here that makes the interaction with the manic patient different than other patients is that these patients, we generally don't encourage them to talk because they're going to have flights of ideas, they're more likely to become delusional, and you're probably going to get very little therapeutic answers from them. So we generally do not recommend the use of open-ended questions. Generally, when you're interacting with the manic patient, you want to use either yes-no questions that are easy for them to answer, or just make statements and don't ask questions. But generally, an open-ended question will probably not reveal any answers that are therapeutic and may end up being uncomfortable for you. Also, these patients need to walk off their energy. So putting them in a larger room where they can walk off and use their energy is to their advantage. To coop them up in a small room where they can't move and they have nothing to do can be very, very uncomfortable for them. So large activity where they can undertake gross motor activity may be comforting. Now, as you probably know, a large number of medications can be used to decrease the movement between moods. And some of those medications used include lithium, carbamazepine, valproic acid, atypical antipsychotics, antidepressants, and benzodiazepines. So that brings us back to that first challenge question. Did you get it right? Let me read it again. A patient presents to the ED in the manic phase of bipolar affective disorder. Which of the following statements made by the emergency nurse is most therapeutic for a patient with this diagnosis? Now, if you need to, pause and make sure you still agree with your original answer, because I'm going to give you the answer now. So the answer is B. I need you to stay in this room and someone will stay with you. Why is that the best answer? What do you think? Well, let's go through all the choices together. What's wrong with A? A is an open-ended question, right? Do you really want to listen to that answer? I wouldn't if the patient's manic. It's probably not going to be helpful in any way. Now, B is a simple statement. It doesn't require an answer and it's brief and short. That makes it the most therapeutic. What's wrong with C? Well, C is just like A. Again, it's an open-ended question. It's going to result in the patient likely rambling, possibly becoming delusional, and really providing you with nothing that's going to be therapeutic or help you in your treatment of the patient. What's wrong with D? D's too long. Remember we said the answer should be 8 to 10 words or so? You know what? On D, your patient's probably going to go back to the spaceship somewhere around danger to yourself. They're done with that sentence. So B is the best answer. Can I give you a little hint on these questions? I'm sure you're going to agree with me. You're just going to think when you get the what would you say to the patient questions, you read the choices and you roll your eyes like, okay, those are all bad answers, right? But it's going to sound like I'm making a joke right now, but I don't mean this to be a joke. I actually mean this. When you get the what would you say to the patient questions, read the 4 choices and choose the one you would least likely say when you're at work to a patient, and you're probably going to get the answer right. And I actually mean that. I think it's because we're not very therapeutic in the emergency department, but that aside, usually the one you would least likely say will be the right answer, so try to remember that. I mean, look at those 4. I don't know about you, but B is the one I would probably least likely say. That I'm going to sit with you in the room? Yeah, that ain't happening. I'm probably going to be saying something more along the lines of, I have a shot for you and we're both going to feel better after you've had that. Anyway, that's enough of that. Next challenge question. Ready? Atropine is effective for overdoses caused by A, antihistamines, B, poison mushrooms, C, LSD, or D, the seeds of Jimson weed plant. I'll let you answer the question and pause if you need to, but I'll move on. Another thing that may appear on the CEN exam is known as a situational crisis. I realize that this may not be a term we use a lot in the ED, but we probably see a lot of patients on this continuum. A situational crisis is defined as ineffective coping, where an individual is unable to solve problems or deal with internal-external stressors. Now, any number of things can throw a patient into a situational crisis. I'm not going to read all the different things that could cause this. They're listed on the bottom of the screen and they're in your handout as well. But anything from moving to a new geographical area to the unexpected death of a loved one, a terminal diagnosis, I mean, you can read the list, can cause a situational crisis. So it starts with one of these events, like a new marriage or a divorce, and the event is either unexpected or it may be anticipated but has unanticipated consequences. And the patient's response to this stressor is shock. And they can have heightened emotions. They can lose the ability to function, to make decisions. They can't even make the simplest of decisions at this point. And they may socially isolate. Now, hopefully they seek help in this stage. At this point, we need to get them hooked into psychiatry or social work or a counselor to help them to find good coping mechanisms. Because if they don't learn to cope with the situation, they can go on to become fatigued, exhausted. They may turn to either alcohol or illegal drugs as a way to cope. They may become suicidal or homicidal, and they may undertake criminal activities. Let's talk about how to manage the patient who's potentially violent or homicidal. So just a few basic things. You probably do these at work anyway, and you've learned about them in your managing aggressive behavior classes, but I think it's worth reviewing because they may be on the exam. So when you have a patient who could be potentially violent or homicidal, you want to make sure you remove their clothing and then check their body for any devices that could be used to harm self or others. They should be placed in a safe environment. Most of us have psychiatric designed rooms in our department that don't have, anything that the patient could potentially harm themselves with and are somewhat escape proof or should be. So we want to put them in those kinds of rooms. Make sure there's nothing in the room that could be used to harm self or others. If you have to enter the room, position yourself in such a way that neither of you is trapped in the room. If the patient were to become violent, you need to make sure you can safely get out of the room with the least risk of being injured. But we also don't want to place the patient in such a way that he or she feels trapped, because that can increase their risk for violence. If it's possible and realistic, keep the door open to the room because that way the patient doesn't feel trapped. Trapped patients can become more violent. Stay calm. Avoid confrontation. Try to establish a therapeutic relationship. And if the patient seems angry, allow them to verbalize their complaints. Many times, patients can talk themselves down if they're allowed to talk about what frustrations they're feeling. Never hurry the conversation. Engage in a therapeutic alliance with them. Use chemical and mechanical restraints as a last resort, and obviously always follow your institutional policy. Now, if you're watching on video, I've put a picture on the screen that kind of demonstrates the position that a nurse should utilize when working with potentially violent patients. Notice that the nurse is not standing straight on at the patient. She's turned at about a 45-degree angle. Now, why is that? Well, when you're turned at an angle, you are you don't look as big. You look much smaller, so you're less threatening. Plus, You're also pivoting so you can get away quickly if you need to. Also, notice how the nurse's hands are put in a position so that the patient can see the palms of her hands. That's because when the palms of the hands are visible, you're less threatening than if the palms cannot be seen. So if you use those positions, you'll never have a violent patient in the emergency department ever again. At least on the test, okay? Let's talk about the suicidal patient for a minute. If you're watching on video, I've just given you 4 pictures of 4 individuals. Just by looking at these 4 individuals, can you tell me statistically which one is most likely to succeed at suicide, to actually die by their own hand? Look at those pictures closely. Now, I'm going to give you the answer. It's D. If you said D, you got it correct. But let's talk about why. So what are some risk factors for suicide? Well, gender is a big one. We know that males will kill themselves 3 times more than females. Now, that doesn't mean females don't attempt suicide. In fact, females attempt suicide more than males. But females are less likely to use a lethal means, therefore they're less likely to die. Men are more likely to die by their own hand. Age is an important factor. Certainly adolescence and young adulthood is a high time for suicide, but the highest suicide death rate actually occurs in the elderly. And that's because they tend to use more lethal means when they get older. Ethnicity. Caucasians tend to commit suicide more than other races. Family history of suicide is an important factor. If somebody in your family has committed suicide, you're more likely to succeed. Sexual minority. Veterans. You know, as I was putting this particular presentation together, I read a stat that jarred me. Some of you may have heard it, but did you know that 22% of suicides in the U.S. today are veterans? Let that sink in. Nearly 1 in 4 people who will die are a veteran that served our country. Is that not heartbreaking? Early life adversity, traumatic events, financial and legal issues, living alone, feeling hopeless or defeated, physical or chronic illness, sleep disturbances, substance abuse, traumatic brain injury, mental illness, access to lethal methods. As you determine a patient's risk for suicide, all of those should be considered. Now, if the patient has attempted suicide and we're left to save their lives, how do we manage those patients? Well, you will want to assess 3 things in the patient who has attempted suicide or claimed to want to commit suicide. The first that you should assess is intent. So, asking the patient, what they hope to do. And, if they say that they're going to die, listen to their plan. Have they created a plan that has a really low probability of being discovered? If they've got a good plan that's very lethal, that there's very low risk of being discovered, that increases the risk that they're serious. You also want to ask about the lethality. What is the means they're using? And the more lethal the means, the more likely it is to be a true suicide attempt. And then how impulsive is the patient? The more impulsive they are, the more likely they are to succeed at suicide. Now, if the patient has attempted suicide, it should be obvious, but your focus in the emergency department will always be on life-saving measures, whether that's treating carbon monoxide poisoning or suturing a bleeding wound. That's your highest priority. But what we mustn't forget in the emergency department is that while we're caring for the physical needs, we also have to manage the patient's psychiatric needs and the suicide attempt itself. So we want to put them in a room and in an environment where they're less likely to harm themselves, make sure that somebody is with them, and so on. And finally, suicidal patients, unlike the manic patient, should be encouraged to talk about their feelings. So always looking for answers such as, how does it make you feel? How did you feel before you put your car in the garage and turned on the engine? Or whatever, you get it. So let's talk now about intentional overdoses and ingestions. Now, to get into this section, I'm going to review something that you took in nursing school and have probably reviewed several times since in various continuing education courses you've taken. But let's talk about the sympathetic versus the parasympathetic nervous system. It's not only going to be important as we talk about overdoses, but as we get into the rest of this course, I'm going to be referring back to this system frequently, so I think a brief review will serve us well. Remember, the sympathetic nervous system is also known as the fight or flight response, and its medical name is the adrenergic system. And that's worth remembering, because you may see the word adrenergic on the exam, and that may not be a word you're familiar with, but if you simply remember to substitute sympathetic for adrenergic, because they're the same thing, the question may make more sense. Now remember, your sympathetic nervous system is fight or flight, so this is going to kick into play when you're threatened. And your brain houses the sympathetic nervous system, but the sympathetic nervous system sends messages down the spinal cord telling your body to respond in a certain way. And those messages will stimulate various receptors in our body. Remember the receptors? There's the alpha receptors, the beta 1 and the beta 2 receptors. Now the alpha receptors are found all over the body, and when your brain stimulates them, it causes vasoconstriction. It causes a process known as glycogenolysis, which is breaking down glycogen in your liver into glucose. Now why would that happen? Well, because if you're going to go running, and this is the fight or flight response, you're going to need energy. So your body takes glycogen and breaks it into glucose and pumps glucose out into your body to make your body have that extra energy source it needs for the flight. Okay, so you're going to have high blood sugars during sympathetic stimulation. The patient will also become diaphoretic. And again, if I'm running, and that's the fight or flight response, I'm going to get hot. So the body just starts sweating even if you're not running when the fight or flight response is activated in order to get rid of heat in your body, evaporative heat loss. So those are the things the alpha receptors do. But when your brain sends messages down the spinal cord, it will also send messages to the beta 1 receptors. Now the beta 1 receptors are found mainly in the heart, and they're going to cause your heart rate to increase, contractility to increase, and automaticity to increase. And if you've forgotten what automaticity is, remember it's the speed at which electricity moves through the heart. So as electricity goes through the atrial pathways and the AV node and the bundles and then through the Purkinje fibers, the speed it goes through there is called automaticity. And the more your sympathetic nervous system is stimulated, the faster that will occur. You also have beta 2 receptors. Those are found mainly in your lungs. Remember how to remember the difference between these two? Beta 1 receptors are found in the heart, and you have one heart. Beta 2 receptors are found in the lungs, and you have 2 lungs. Does that help you? But when your beta 2 receptors are stimulated, it's going to cause your respiratory rate to increase, and you will bronchodilate. So that will improve gas exchange for the fight and flight. Okay, that's sympathetic. So your sympathetic or adrenergic nervous system is stimulated when you're in trouble and you're getting ready to fight or flight. Now the parasympathetic nervous system is known as the rest and digest system. It also has a medical name, which is cholinergic, and I would remember that when you see the word cholinergic on the exam, you may replace it with parasympathetic. Now, when the parasympathetic nervous system is stimulated, it will also stimulate the alpha, beta 1, and beta 2 receptors, and basically what happens is it just reverses everything. This is kind of like your homeostasis, which it just brings everything back to its original state. So when you're scared and you're fight or flighting, your sympathetic turns everything on and speeds it up. But then when the threat is gone, then your parasympathetic takes over and just reverses everything. So the symptoms of sympathetic stimulation include vasodilation, glycogenesis, which is just putting glucose back into the liver and taking it out of the bloodstream, reducing blood sugars. The skin will become dry. The heart rate, contractility, and automaticity will decrease. The respiratory will decrease, and the patient will bronchoconstrict. Remember all that? It's worth really paying attention to this chart because we will be referring to it numerous times throughout this course in relation to various disease processes. But right now, I want to apply it to toxidromes, because remember we were talking about overdoses. Now, what's a toxidrome? A toxidrome is a set of symptoms that a patient experiences when they overdose on a particular substance. There's 5 toxidromes, and let me give you some advice. They're in your book, and I would recommend you take the time to memorize these in preparation for the exam. If you know these 5 toxidromes, it will help you answer nearly all of the toxicology and overdose questions you may get on the exam. So it's a great use of your time. But let's go through them. So let's start with the sympathomimetic toxidrome. Now let's just break that word down. Sympatho would be for the sympathetic nervous system, and mimetic means it mimics. So if we say this mimics the sympathetic nervous system. Okay? So basically, if you overdose on the substances on the screen right now, your sympathetic nervous system will go into overdrive. Notice that most of the drugs on this list are going to be your illicit street drugs, from LSD to cocaine to meth and everything else in between, bath salts and you name it, ecstasy. Now you might, or let me say differently, you might remember that sympathomimetics are going to be your illegal drugs, because why do people take illegal drugs like cocaine or meth? What are they looking for? A high, right? They're looking for that surge of adrenaline, which of course the sympathetic nervous system surges adrenaline into the system. And some people like that feeling you get when you have adrenaline in your body. Okay, I'm going to admit it. I'll raise my hand. I like the sympathetic nervous system feeling. I love a surge of epi, and I do stuff that makes me have surges of epi. I love to, downhill ski. I like to skydive. I like to zorb. I like to whitewater raft. I like to do crazy hikes on cliff faces, because I really like the feeling of that epi coursing through and giving me that edge, right? The only difference between me and people who use illegal street drugs is I do mine legally and they do theirs illegally. And I probably spend about as much money as they do, unfortunately. Now, there are some prescription drugs that are also sympathomimetic. They're listed there on the screen and in your book, so you should be familiar with those. Now, I just kind of gave you the answer to this toxidrome, so I left the blanks in your book, blank. So let's go through the symptoms of a sympathomimetic overdose and see if you can figure them out. So this would be, for example, somebody who overdoses on cocaine or meth. What is their toxidrome? Well, here we go. What will the blood pressure be with a sympathomimetic drug, high or low? Did you say high? Well, you got it right, because remember, these cause vasoconstriction. Vasoconstriction is going to cause the blood pressure to go up, and it can go up a crazy amount. Now, that vasoconstriction can also reduce circulation to the cells, which can cause a secondary lactic acidosis. It can cause spasms of the coronary or cerebral arteries, leading to an MI, a TIA, a stroke. It can cause the blood pressure to get high enough to cause an aortic dissection. It can cause vasoconstriction of the nasal septum, leading to perforated nasal septums. So we're talking about a lot of different things that can occur due to the vasoconstriction. Heart rate, high or low with sympathomimetic? It's going to be high, right? We said that the beta 1 effects cause an elevated heart rate, so high heart rate. How about the respiratory rate? High, right? That's your beta 2 effects. Diaphoresis? Well, I'm going to say high, but you could have said yes as well. But the alpha effects are going to cause the patient to become very sweaty. Mental status? Let's go with high. I think that works in every way, right? They are high, but they also have an elevated mental status, or they're agitated. And they can be so hyperactive they can get muscular rigidity and even rhabdomyolysis. The temperature, high or low? It's going to be high because of all that muscular activity. They're going to generate heat, and so they tend to get really high temperatures. Pupil size, high or low? Now we could also say constricted or dilated, but the right answer is high or dilated. Because remember, this is fight or flight. If you're going running, you want as much light in that pupil as you can get, so you're going to dilate to let in more light, so they'll get dilated. Now I'm going to give you the last one rather than asking you, because who would know it, but vowel sounds are neutral. They're not affected. There you go. There's your toxidrome. Make sure you fill it in on your handout so you can look at it later. But notice that for the most part, all of the arrows are upward facing because this is going to be a stimulant. Now the second toxidrome we're going to look at is the anticholinergic. Now this is where the words I taught you just a few moments ago will help. Cholinergic is another word for what? Parasympathetic, right? So if we replace the words, an anticholinergic could also be called an anti-parasympathetic. So basically, these drugs, this toxidrome is going to block the parasympathetic nervous system. So think about it. If you block the parasympathetic nervous system, then what system is dominant? Well, the sympathetic, right? So in a lot of ways, the anticholinergic toxidrome is nearly identical to the sympathomimetic because one blocks the parasympathetic, the other stimulates the sympathetic, but they both result in sympathetic stimulation. So look at the arrows. They're nearly the same. But there's one big difference we have to talk about, and that's diaphoresis. An anticholinergic is going to cause a unique muscarinic effect, which is going to cause everything to dry up, and the patient will make no fluids. So while the sympathomimetic person was really sweaty, the anticholinergic person will be really dry. Remember the mnemonic for this one? It's on your screen. Blind as a bat, because you're mydriatic. Red as a beet, because you get really flushed. Dry as a bone, because you make no fluids. Mad as a hatter, because you go psychotic. And hotter than Hades, because of that elevated temperature. So what types of things fit the anticholinergic toxidrome or would cause this? Well, let me read them quick. Atropine, antihistamines, tricyclic antidepressants, cyclobenzaprine, drugs to treat Parkinson's disease, antispasmodics, mydriatic eye drops, and certain plants. Now, some of you who live in the deeper south especially may recognize Jimson weed. Jimson weed grows in the wild like the ditch. There's little seeds and people can use it to get high. But if taken in large doses, it can cause an anticholinergic toxidrome. The leaves of the potato plant, the leaves of nightshade plants, they're also anticholinergic. And kids or even adults who use these can end up in an anticholinergic toxidrome. Now, how do we manage a sympathomimetic and anticholinergic toxidrome? Very similarly, because these two toxidromes are nearly the same, the treatment is basically the same. So, because they're going to be really tachycardic and really agitated, we'll use large doses of benzodiazepines. Now, when I say large doses, that is not a joke. How many of you have ever had to give a benzodiazepine for one of these overdoses? It's crazy how much you give, right? Like 15 or 20 milligrams of Ativan. That would kill me. But these patients can take it because of their agitation. So you just keep pushing the Ativan until their heart rate is down to a normal level. Nipride can be used to manage the high blood pressure, and then remember they're really hot. Temperatures, up in the dangerously high levels, so cooling blankets, cool normal saline, and the like can be used. And then Haldol for psychosis. And that's how we'll manage this overdose. Now, the third toxidrome is going to be the cholinergic. So, of course, cholinergic should be, what word do you substitute here? Parasympathetic. So the cholinergic toxidrome is just simply a set of drugs that causes a parasympathetic stimulation. As you would expect, a lot of the arrows are going to be in the opposite direction of the anticholinergic, and these are going to cause the muscarinic effects. And let me tell you the best way to remember this one. Just remember this simple statement. If water comes out of a hole, lots of water will come out of that hole. So think of all the holes you have in your body and just think of water coming out of it. They're going to sweat profusely. They're going to lacrimate. They're going to froth at the mouth. They're going to urinate in their pants. They're going to have diarrhea. Any hole that makes water will just flow out of them. Now, there is a mnemonic you could use to remember this one. It's dumbbells. I won't read it to you, it's on the screen, but it basically just goes over all the different types of water coming out of your body. I don't like to dwell on this because it's so sad and inhumane, but it's worth mentioning. Some of you may remember quite a few years ago now, in Syria, Bashar al-Assad, the leader of Syria, gassed his own people. And he used sarin gas, which was cholinergic. Now, because we live in the day of cell phones, people were able to film what happened that day when they were attacked. And we saw the horrible videos on the news of people lying around on the ground after the attack. They were seizing. Most of them were incontinent in their pants. They all had froth on their mouth. Their skin was sweaty. Their hair was matted. You could see the incredible effects, the cholinergic effects of sarin gas. And we all on TV had to watch what a cholinergic toxidrome will do. Now, what things cause a cholinergic toxidrome? Well, I just mentioned one, organophosphorus warfare agents like sarin, soman, tubin. If we're ever attacked chemically, it'll probably be a cholinergic gas. But insecticides also cause this. You know, farmers or migrant workers working in fields that have recently been sprayed with an insecticide may come in as a cholinergic toxidrome. Physostigmine, certain poison mushrooms, pilocarpine, nicotine. Those are all examples of cholinergic substances. Now, the treatment for a cholinergic would be to give the patient an anticholinergic. And what's the most abundant anticholinergic in the emergency department? Oh yeah, atropine, right? It's anticholinergic. It's going to reverse the effects of the cholinergic toxidrome. So we just push atropine. And it says on the screen, and I'm going to reinforce it, it takes large quantities. Here we are again. Have you ever done this? You just keep pushing the atropine until the patient's heart rate's normal. That can take 20, 30, 40 mgs of atropine. Yeah, I said it, mgs. Remember, one of those boxes like you see on the screen is a half a meg. So you could be giving, 40 to 80 boxes of that stuff. But they can take it. You just keep pushing it until their pulse is normal. There is another drug that can be used. It's known as pralidoxime or 2-PAM. Now, this one is used more in the military. Our military will carry it when they're deployed, so they could quickly auto-inject themselves should they be attacked chemically. But it could be given to civilians if it's available in your hospital. Has to be given within 1 to 2 hours of the exposure for best results. Now, these patients are going to develop severe pulmonary edema because they're going to make fluid in their lungs, right? Water out of every hole. So the lungs are going to fill with fluid, and they're going to need intubation for pulmonary edema and possibly suctioning. And then benzodiazepines if they develop seizures. So here's our challenge question. Atropine is effective for overdoses caused by what? Well, I just said it, so now it should be obvious. Let me reveal: poisoned mushrooms. Yep. Now, if we look at the others, antihistamines, well, we haven't talked about those yet, but they get their own toxidrome. LSD, what kind of substance is that? It's a sympathomimetic, right? We don't use atropine on a sympathomimetic. And then the seeds of the Jimson weed plant, what kind of toxidrome was Jimson weed? That was an anticholinergic, right? We wouldn't want to use atropine on that. Atropine's used for the cholinergic. So there you go. B is correct. Okay, next challenge question. The following rhythm strip is noted on the cardiac monitor. Which of the following substances did this patient most likely overdose on? A, digoxin, B, lorazepam, C, ethylene glycol, or D, acetaminophen. This is an analysis-based question, and that's because it's not just a pure recall. You can't just recall. You have to analyze this question. First, you have to look at that rhythm strip and figure out what it is. Then, when you know what it is, then you have to figure out which substance would cause that rhythm strip. So these are challenging questions, and over 20% of the questions on the CEN will be analysis like this one. Okay. Let's talk about the fourth toxidrome, which is an opiate overdose. Oh my goodness, if you don't care for an opiate overdose every day you're at work, you probably don't work at a hospital in the US. So I won't spend a lot of time on this toxidrome, but basically you'll notice that nearly all the arrows are down facing, because this is going to be a suppressive type of a substance. So the treatment is ventilatory support. I think we all know they quit breathing on a dime, and then Narcan. Narcan can basically be put in any hole the patient has on their body for the most part, and it will work, but I've listed the different places you can give it there on the screen. Now, the thing to remember, not a big secret, but Narcan has a very short half-life, much shorter than most of your opiates, so therefore, the Narcan will often wear off before the opiate will. Let's use heroin as an example. Heroin has a half-life of 6 hours. Narcan, 30 to 60 minutes. So if you have somebody who's on a heroin overdose, they may not be breathing. You give them Narcan, they wake up and they're breathing, but then in 60 minutes they may go apneic again, and you either need to give them more Narcan or put them on a Narcan drip. Let's talk about withdrawal from opiates. So you have an individual who is addicted and they either come in and we give them Narcan, which puts them into withdrawal, or they're trying to stop and they go into withdrawal. So your short-acting opiates like heroin or morphine are going to have a very brief but intense withdrawal. The symptoms of withdrawal usually start 4 to 6 hours after the last dose and will tend to peak about 2 to 3 days after the last dose. Most patients will move through the withdrawal period over a period of 5 to 10 days and normalize. Now, a long-acting opiate such as methadone has a milder withdrawal, but it takes longer. Usually the onset is 24 to 48 hours. However, because it's long-acting, the patient may have symptoms of withdrawal that could last for weeks. Now, the symptoms of opiate withdrawal are listed on the screen and in your handout. I won't take the time to read them. I recommend you read them and be familiar with them. It's fair game to ask a question on them, but you can read them on your own. So what's the treatment? Well, provide opioids, right, for withdrawal. Now, we certainly do not need to feed the addiction, so we don't need to give them heroin. And obviously, we can use, buprenorphine or methadone or something else, but we can provide opioids. Do remember that it will probably take a larger dose of opioids for these patients who have a dependence on the drug. And if you're using opioids to manage the pain of somebody with an opioid dependence, you're going to have to consider using much higher doses than you would otherwise. Now, there's a fifth toxidrome, and that is your sedative hypnotics. Now, drugs that fit the sedative hypnotics toxidrome include barbiturates, or drugs that end in tol, benzodiazepines, or drugs that end in PAM, antihistamines, and alcohols. Now, if you look at the toxidrome in the book or on the screen, notice how all the arrows are down facing, because this is going to be a suppressant again. It's a sedative, so it's going to suppress everything and slow everything down from heart rate to respiratory rate to mental status and so on. Now, I want to pull two of these sedative hypnotics out and talk about them special. And the first one I want to talk about special is benzodiazepines. Now, benzodiazepines are going to have a very similar effect as a narcotic. They're going to cause profound CNS and respiratory depression. And your highest priority will have to be protecting the airway. Now, there is a reversal agent which is rarely used, and that is flumazenil or romazicon. I know this isn't a big secret, but I'm going to ask it anyway. What do you worry about if you give romazicon to a benzodiazepine overdose? What's your biggest concern? I'm going to guess most of you immediately said seizures, because we kind of know that. But what I did think I would take a minute to talk about is why. Like, is it a side effect? Well, not really. Think about this. You have a patient who's been on Valium for 10 years. They have a dependency on it. Today's the day they choose to kill themselves by taking a bottle of diazepam, and they overdose, and they come in with a GCS of 3. So we push flumazenil on them, right? And we block all their benzo sites. All right, so now their benzo sites are blocked. And so now they're going to wake up, but they're going to go into Withdrawal, right? All right, so they're in withdrawal and they start to seize. They have a withdrawal seizure. So what do you give them for the withdrawal seizure? Well, wait, you can't give them Ativan because you benzo-block them. All their benzodiazepine receptor sites are blocked with flumazenil. So now the Ativan won't work. So guess what you just created? Status epilepticus. Do you see the problem? So could we use flumazenil? Yeah, sure. I got a 2-year-old who got into grandma's Ativan. Guess what? He's not addicted. He's not going to seize. You could safely give him flumazenil. But if I got a 30-year-old overdosing on Valium and I don't know their history, it's not worth the risk. That patient just is going to get a really, really, really long nap out of it, right? Okay. Let's talk also about alcohols. I know for those of you that work Friday evenings in the emergency department, you do not consider alcohol to be a sedative, but you know it ultimately gets there. It becomes a sedative with time, and then all the arrows are down facing. So let's talk about your 4 alcohols for a minute. There are 4 of them: ethanol, methanol, ethylene glycol, and isopropanol. And what you may not know, I didn't know this till I started studying this stuff, is that all 4 of these give you an equal buzz. You can drink windshield wiper fluid if you're crazy enough. You can drink antifreeze if you're even crazier. Or you can drink bourbon and you get the same buzz. So there are people who are going to drink things like antifreeze because it's cheaper and easier to get than bourbon, right? And they get the buzz. What they may not know is that while all these alcohols are equal initially and give you the same buzz, about 24 to 72 hours after you take them and the liver metabolizes them, the metabolites are what are so dangerous to the body. And that's when these become life-threatening, is in the phases several days after ingestion. So let's look at these 4 alcohols uniquely because they all have different metabolites. So ethanol is the one found in things like alcoholic beverages, mouthwashes, and it can also be found in over-the-counter medications like cold medications. Now, an overdose on these can cause hypoglycemia, and children are especially vulnerable here because they have poor glycogen stores. They can also have an altered mental status. Well, obviously, we all see that on Friday night shift. Now, your chronic alcoholics who drink regularly can develop hypomagnesemia, and this is one of the main causes of low magnesium. We'll be talking more about low magnesium in the medical lecture coming up, but hypomagnesemia is common to chronic alcoholics. And then Wernicke-Korsakoff syndrome is a thiamine deficiency. Thiamine and alcohol can compete in the intestine for the same binding sites, and so patients who are chronically alcoholic or chronic alcoholics may have low thiamine levels. And low thiamine can degrade the brain and lead to Wernicke-Korsakoff syndrome, which can cause things like confusion, nystagmus, altered gait, and ultimately long-term brain degradation resulting in hallucinations, delusions, and even requiring institutionalization. That's why, as much as I hate saying it, we want our alcoholics to come to the ED about every 3 months. They need their thiamine, otherwise they're going to develop Wernicke-Korsakoff syndrome. A lot of big cities, like the one I live in, we have thiamine clinics downtown, so they don't have to come to the emergency department for thiamine. They get it downtown, but somebody somewhere got to give them thiamine every few months. And of course, anytime an alcoholic comes into the ED, give them 100 milligrams of thiamine, and that just pumps them up for preventing Wernicke-Korsakoff. Also, we'll want to give them a banana bag to give them those electrolytes like magnesium they need, and then airway protection if they have a reduced level of consciousness. Now, the next 2 on the list, methanol and ethylene glycol, these are sweet tasting. They taste better than ethanol, believe it or not. Most of these products, they'll put vinegar in them so that pets or even people don't drink them, but they're still very sweet and good tasting. And both of these, if you overdose on them, will cause a profound metabolic acidosis. And that's going to be your biggest challenge, is combating that acidosis. Now, methanol is also hard on the GI tract, causing nausea, vomiting, and abdominal pain. And methanol is known in higher doses to cause blindness because the metabolites that occur like 72 hours or so after ingestion can destroy the optic nerve. Ethylene glycol can kill the kidney. leading to renal failure. Now, the treatment is, of course, going to be to manage that acidosis with sodium bicarb, and then famotidine is an alcohol antagonist. So it will bind with the sites in the liver that break down the alcohol, and that prevents the alcohol from breaking down. So famotidine is used, and that will slow the degradation of the alcohol, and that just buys time for the body to get rid of it before it metabolizes. Now, if they're in really high doses, or they're well into their overdose, they're kind of getting into that danger zone of 48, 72 hours, dialysis may be required to dialyze the alcohol out of them. The last alcohol is isopropanol. This one's found in things like rubbing alcohol and glass cleaners. Now, this one is a little less toxic than the previous two. Now, I don't want to give the impression it's not a serious overdose. It is. But this one causes more of a DKA-like effect. Hyperglycemia, ketosis, osmolar gap, fruity odor to the breath, profound CNS depression. Now, fomepizole does not work for isopropanol. So these patients are going to be treated almost like they have DKA. Insulin and those things that you would give to a DKA patient, fluid replacement and so on. So there you go. There's your 4 alcohols. Let's talk about alcohol withdrawal for a moment. So many people will kind of progress through alcohol withdrawal in a very predictable way. 12 to 24 hours after their last drink, they may become very dysphoric, and they may develop an autonomic hyperactivity. So you get, remember autonomic is, what's the other word for it? The sympathetic nervous system. So tachycardia, hypertension, diaphoresis, everything we just talked about. And they may have GI upset. Now, around 24 to 36 hours post-drink, that autonomic hyperactivity heightens. That's when they're going to have the highest pulse and the highest respiratory rate. Their tremors are going to become coarse. And this is where you may begin to see auditory, visual, and tactile hallucinations. So you can add tactile to the list now. 36 to 72 hours after their last drink is when the risk for seizures begins. And so we have that high risk for seizures. Now, the seizures tend to be short and they tend to be self-controlled, so we don't usually see status epilepticus, but we can see many seizures, as you know. And then 72 to 96 hours after their last drink, if they're going to develop DTs, this is the time. At 72 to 96 hours, with extreme autonomic instability that can sometimes cause the real extremes of the blood pressure and pulse, even to the point of cardiovascular collapse. They can have fluctuations in their level of consciousness. They can become delirious, have the coarse tremors. They can have the elevation in their vital signs, nausea, and vomiting. And DTs can last 3 to 5 days. And this is a potentially life-threatening time for them because of the autonomic instability. Now, the treatment for alcohol withdrawal across this entire continuum is benzodiazepines. And it is important to note that the earlier the benzos are started in the withdrawal period, the more likely they are to work and the lower dose that's required. Haldol may be used here. It's very effective for the delirium, but it increases the risk of seizures, and that needs to be considered. All right, so let's move on now to overdoses that require antidotes. All right.
As a mom with 3 active kids, I've got to make sure I know what they're up to at all times. And as any mom will tell you, they can be a handful. That's why I give my kids Kidstone Chewable Valium.
Kidstone Chewable Valium, the barbiturate the whole family can enjoy.
And once the Kidstone Chewable Valiums kick in, these kids kind of stay right where you put them. They're quiet, relaxed. It's a dream. And just about all you have to do is check their breathing every once in a while or just poke at them with a stick.
Kidstone Chewable Valium, from the makers of nitrous oxide balloon animals.
All right. As silly as that video is, we're going to move into some serious stuff here. We're going to talk about overdosing on substances that have antidotes. Let's see how well you know your antidotes. So let's start with calcium channel blockers and beta blockers. And I want to start by making a very obvious statement, but sometimes an obvious statement needs to be made, so I'm going to make it. And that is that when you get questions on the exam related to a prescription overdose like calcium channel blockers or beta blockers, don't memorize all these symptoms I'm about to give you, because you can figure the symptoms out by just thinking about what a drug does therapeutically. Calcium channel blockers, let's use an example. What do they normally do to the heart rate if you give somebody a calcium channel blocker? Well, yeah, they make the heart rate go down, right? So if you overdose on a calcium channel blocker, what's going to happen to the heart rate? It's going to be really, really low. Maybe even a heart block, or maybe even asystole, but you can figure that out. You don't need to memorize that. So just keep that in mind. So what are the symptoms of calcium channel blockers and beta blockers? Well, they're on the screen. Hypotension, and then cardiac disturbances like bradycardia or heart blocks. Now, these can cause blood sugar abnormalities, and this is one you might have to memorize. This is a weird little thing, but calcium channel blockers cause hyperglycemia, whereas beta blockers cause hypoglycemia. So there's a little difference in the two, and that's because calcium channel blockers inhibit insulin release and beta blockers stimulate the alpha receptors. So you get that little difference between these two. Now, if they're taking a short-acting drug, then the onset of symptoms will often be within 30 minutes after ingestion. If they're using extended release, it may take longer for the symptoms to start, but then of course they'll last longer. All right, this is my challenge to you. What is the antidote for calcium channel blockers? And what is the antidote for beta blockers? See if you can get it without me telling you. Pause if you need to, because the answer is, well, for calcium channel blockers, calcium chloride, and for beta blockers, it's glucagon. So those are your two antidotes. Now, aside from the antidotes, we can also treat the patient's symptoms. So fluid boluses for hypotension, but remember they're at risk for heart failure, so be careful with those fluids. And then for the cardiac disturbances, they may need transcutaneous pacing. Now note that atropine is unlikely to be effective for the bradycardias here, so you're using pacing rather than atropine. And then, as I already said, IV calcium for calcium channel blockers, and you usually give 1 gram of calcium chloride over 5 minutes, and then you wait to see, does the heart rate come up? If it does, great. If not, you can repeat it every 15 to 20 minutes for 3 to 4 doses, but just watch their serum calcium, because you don't want that to get too high, or they got a whole other set of problems. So we tend to only give enough calcium to get the serum calciums up to 11. And let me be real honest with you. If they took a huge dose of calcium channel blockers, there may not be enough calcium to save them. This can be a fatality for patients who take really high doses, because you can only give them so much calcium before you create a calcium imbalance on top of everything else. But certainly we can give a few doses of calcium, and in low to normal doses of overdoses, that'll be effective. Now, glucagon is used for beta blockers because it enhances cardiac contractility. It could be used for a calcium channel blocker overdose, but it's going to make the hyperglycemia worse. So we try to use calcium instead for the CCB overdose. All right, next one. Digitalis or digoxin. Now, of course, you can overdose on digoxin by, well, just taking a bottle of digoxin, or getting into a dig-containing plant. Plants that contain dig include foxglove, oleander, lily of the valley. So those are going to be your dig plants. And then you can also overdose on dig by taking digoxin with other cardiac meds. Now, the symptoms, again, should be what you would expect from this drug. So hypotension and dysrhythmias like heart blocks, bradycardia, ventricular arrhythmias, asystole. They can get really bad hyperkalemia. And when I was researching this, they talked about that being one of the most challenging things to manage in your digitalis overdose is the hyperkalemia. Anorexia, nausea, vomiting, mental status changes. And then with your more chronic overdoses, they may get those yellow or green halo around lights, or just yellow-green vision. So those are all signs of digitalis overdose. Okay, the next question is not that hard. I'm sure you can get it, but what's the antidote for this one? Yeah, I'm sure you got it. Digibind, or digoxin immune fab. Now, the decision to give this is not a small deal. but we generally will use digibind if the patient either has arrhythmias related to the overdose, or their serum potassium is above 5, or their serum dig concentration is above 10 micrograms per deciliter. Those are all indications for digibind. And then for the bradycardias, atropine or cardiac pacing, and for the ventricular arrhythmias, magnesium may be used. So, did you get the question right? Let's look at it. The following rhythm is noted on the cardiac monitor. Now this is analysis, so we have to start. What is that rhythm? Did everybody recognize it as a third-degree heart block? Well, if you did, you got it correct. So the next part of the question is, which of the following substances did this patient likely overdose on? And the one on there that causes heart blocks is digoxin A. The other three are not associated with third-degree heart blocks, so A is the best answer. All right, next question. Effective treatment for an overdose on a tricyclic antidepressant should cause A, widening QT interval, B, serum pH above normal, C, decreasing blood pressure, or D, dilation of the pupils. Can I just warn you ahead of time on this question? This is another one of those tricky questions that can play with your brain in a bad way. It's called an evaluation question, where you're evaluating your care. More than 20% of the questions on the exam will be like this, where you evaluate the care. So effective treatment should cause. So this one is saying it's the opposite of what you're thinking. So it's saying that if the patient is treated correctly, which of those will occur? A lot of times it's easy to read these questions and think, oh, which one is a side effect of a tricyclic antidepressant? No. You'll get it wrong if you read it that way. This is saying effective treatment should cause. So it's kind of the opposite of the symptom. It's saying which of these means that the patient's getting better. Evaluation-based question. Be careful with them. Okay. Let's move on and talk about antihyperglycemics. So these are your sulfonylureas and your meglinotides. Now, both of these are obviously going to cause hypoglycemia. The pediatric patient is especially vulnerable because they don't have glycogen stores. But also, besides hypoglycemia, they may have CNS depression and they may develop seizures. Now, I have to talk about metformin special because, as you may know, it has a different mechanism of action. Therefore, it does not cause hypoglycemia. It's different than the others in that its main effect is going to be a life-threatening lactic acidosis. And you need to know the difference there. Oh boy, am I going to challenge you now. What is the antidote for this one? This is hard. If you can get it right, pat yourself on the back because you really have a good knowledge base here. The antidote is octreotide. I'm going to guess most of you are like, what? I use that for GI bleed. Well, yes, you do, but it also blocks insulin production, so it becomes an antidote as well. Now, when we treat the patient with an antihyperglycemic overdose, they're hypoglycemic, so if they still have a gag, giving them food or juice with a lot of sugar in it is appropriate. If they lack a gag, you may give them a dextrose infusion just to immediately give them an infusion of sugar. And then you're going to give the octreotide, and it's given IV, and you can see the dosage is listed there. And now for metformin, remember they don't get hypoglycemic, so their treatment is sodium bicarb and dialysis for the profound acidosis. Next is your anticoagulants, all kinds of them, from warfarin to heparin to fragmin and everything in between. So if somebody overdoses on these, of course they have a high risk for coagulopathies and any kind of bleeding, from external bleeding to intracranial hemorrhages to GI bleeding and everything in between. I won't even ask you to guess the antidotes for these, although you should know the one for warfarin and heparin. But a lot of them are really strange. They're in fact names I can't even pronounce, but here we go. So you can see on the right-hand side of your screen the various types of anticoagulants and the antidote for each. I will not even embarrass myself by trying to read these names, but they are in your handout. They are in the book if you want to familiarize yourself with them. And my challenge to you is see if you can pronounce them better than I can. I'm going to guess a lot of you probably can. Let's keep moving. Salicylates and NSAIDs. You know, these two overdoses are not typically that serious. People do try to kill themselves with it, but rarely are they successful because patients sometimes don't even get that sick. But even in high doses, the illness is rarely life-threatening. But on the screen now, you can see the side effects of a salicylate and an NSAID overdose. So if I quickly review them for salicylates, they get hypotensive, a metabolic acidosis, an elevated respiratory rate leading to respiratory alkalosis, renal failure, coma, convulsions, and then obviously bleeding due to decreased platelet function. So that would be a salicylate or aspirin overdose. And then an NSAID overdose can, as you would expect, cause GI upset and bleeding, renal damage, drowsiness, coma, acidosis, bradycardia, and apnea. I won't ask you about the antidote here because there really isn't one. These ones just require supportive therapy. So for salicylates, they're often profoundly dehydrated and need large volumes of crystalloids, as many as 4 to 6 liters. And then because their acid-base balance is out, they may need sodium bicarb with a goal of a serum pH of around 7.5 and IV potassium with a goal of serum potassium between 4 and 4.5. That's the mainstay of treatment. NSAIDs, because of the GI bleeding and the difficulty with the GI tract, proton pump inhibitors should be given to protect the GI system. If they're hypotensive, IV fluids and vasopressors, and benzodiazepines for seizures. And that's about all we'll say here. Tylenol. Tylenol isn't really an emergency department overdose. This is the one that they get sick a few days later. They come into the ED because they just took Tylenol, but they don't get sick for a few days. Tylenol has 4 very predictable stages, and they're listed on the screen. Now, stage 1 is the one you and I will see. Within 24 hours, anorexia, nausea, vomiting, malaise. Not very dramatic. Now, should the patient come in 2 to 3 days afterwards, they may actually come in with the beginning of hepatosis, right? So they could have right upper quadrant pain, hepatic tenderness. They may begin to have elevating liver enzymes and elevating PT. At days 3 to 4, they become anorexic again, and now they're going into full-blown liver failure. So encephalopathies, jaundice, metabolic acidosis, full-blown coagulopathies, renal failure, and pancreatitis. And then stage 4 usually occurs 5 or more days after the overdose, and at this point the liver and kidneys fail, and they go into a multi-organ dysfunction syndrome and may die at this point if they don't get treatment. Now, what of course is the antidote for this one? I'm sure most of you give it, so you know it is. Yeah, your Mucomist or which we give an IV or PO. So survival is highest if it's given within 8 hours of ingestion, ideally. So you want to try to give the Mucomist either PO or IV as soon as possible after the ingestion, but certainly within 8 hours. Now, I'm not here to say you couldn't give it after 8 hours, but the effectiveness starts to decrease, right? You want to get it in there before the liver starts breaking the Tylenol down. So the earlier it's given, the more effective it's going to be. Can be given PO or IV and repeated as needed based on the nomogram. If you're not familiar with the nomogram, because mainly ICU uses the nomogram, so I'll just mention it. It's on your screen, but notice that chart. So what we do is at regular intervals after the overdose, we actually measure the Tylenol level, and then we plot it on that nomogram. And if it falls above the blue line, they need another dose of Mucomist. If it falls below the blue line, they don't. So it just tells us whether they need more Mucomist. Sometimes we can give like 17 or more doses of Mucomist in the days after the overdose based on where they plot on the Matthew Romick nomogram. One thing also to mention, if you're giving IV Mucomist, the anaphylactoid risk is really high, like 4 to 17%, so be aware of that. Okay, you ready for some sweet words? And finally, yes, we're almost done here. Cyclic depressants. Antidepressants. So your cyclic antidepressants. Now remember, we sometimes used to call these tricyclics. Sometimes now there's some quadcyclics, but I remember tricyclics, and tri means 3. So just remember, they're tricyclics, tri is 3, and there's 3 main effects related to tricyclic overdoses, and they are anticholinergic. So we already talked about an anticholinergic as an overdose, right? Causes dry skin, dry mouth, decreased level of consciousness. The second of the tri is adrenergic blocking. So they're going to get profound hypotension due to vasodilation. And then the third component of the tricyclic is the cardiotoxicity. Basically, what a tricyclic will do, or any of your cyclic antidepressants, is it's going to slow conduction through the heart. And so the heart's going to just contract really slowly. And how you'll see that is on the EKG or the monitor, everything will stretch out. And they'll get the really wide QRSs, the wide PR intervals, the wide QTs, the wide T waves. Everything will look stretched out and bizarre. And that's one of the findings. And that's why they often die. Because I can fix the hypotension due to vasodilation, because I can reconstrict you. But I can't fix the hypotension due to a really, really, really slowed down heart rate. And it may be hard to change that slowed contraction or automaticity. Now, does anyone know the antidote for this one? If you've given it, you'll never forget, but I'm going to guess a lot of you have never given it, especially since we don't use cyclics that much anymore. They're still used for things like pain and so on, but we don't use them much for depression. Well, the antidote is sodium bicarb. Your goal when you give the sodium bicarb is to give enough to keep the serum pH between 7.5 to 7.55. That's called alkalinizing the serum. And the more alkali the serum is, the more it decreases the negative cardiac effects, the widening of everything. So that's why we do it. So you're going to usually add a couple amps of bicarb to every liter of solution you give. Now, these patients can also become hypokalemic, so you may need to administer potassium. They will also, if they're hypotensive, need fluid boluses and vasopressors. And then for the arrhythmias, amiodarone and lidocaine can be used. Note that if you're given the choice of procainamide, do not choose it on the test, because procainamide will further widen what's already widened, right? Transcutaneous pacing for heart blocks, benzodiazepines for seizures. These patients are a lot of work. A lot of them do not survive. But when they do come in, it often takes the entire ER team in the room working feverishly to keep these patients alive, throwing the vasopressors at them, dealing with their arrhythmias, giving them the sodium bicarb. There's so much going on at once, and they're very, very difficult to save. Now, the question. Effective treatment for an overdose on tricyclic antidepressants should cause a... Look at them again. Well, let's go through them. Widening QT interval? No, because it's already wide. So if it's widening, you're making them worse. So A is wrong. B, a serum pH above normal. Yeah, that's the right answer, because remember, we want to keep the serum pH 7.5 to 7.55. Helps to reduce cardiotoxicity. C, decreasing blood pressure. No. Effective treatment should elevate the blood pressure because they're already low. You don't want it lower, so C is wrong. And D, dilation of the pupils. Nah, overall tricyclics don't affect the pupils, so your goal is not to change the pupils. And that is the end of mental health emergencies. So I hope all of that made sense, and I hope you will do well on this section on the exam. We'll see you in the next module.